Um, Thank you for joining our first Preparedness and Treatment Equity Coalition event, otherwise known as PTEC. My name is Jennifer Mascarenhas. I am an anesthesiologist and the Chief Medical Officer here at PTEC. Just a couple housekeeping notes. We tried to make this a webinar, which we were unable to at the last minute. So if you would please mute yourself and turn your cameras off if you're not speaking, that would be appreciated. And if you have any questions that come up throughout this, this meeting, please direct them to Benson, Sue, or to everybody in the chat, and we'll try to get to them at the end. We have a great lineup for you today, and we'll delve right in. But first, I'd like to give a brief background on PTEC, since this is our first event. PTEC was founded during the pandemic as alarming evidence emerged that racial minorities and socioeconomically disadvantaged groups are experiencing a disproportionate burden of illness, hospitalizations, and death due to COVID-19. The Black, Latinx, and Native American communities were already experiencing significant healthcare disparities during the pre-pandemic times. These communities have well-documented increased incidence of pre-existing cardiovascular and metabolic conditions, which we know now increases their COVID-19 morbidity and mortality risk. The existing health disparities already experienced by these communities are increasing due to COVID-19, and it is important to understand why these gaps exist and how health policies have fallen short for racial minorities and socioeconomically disadvantaged communities. PTEC will focus on metrics and reimbursement and is bringing together various sectors of healthcare, such as healthcare providers, researchers, life sciences companies, and advocates to study and address the inequities in pandemic preparedness and treatment. We have received generous support and funding from 9 life sciences companies to date, as well as pro bono assistance from 2 others, and we have filed as a 5013C. We are working on a research agenda for 2021, and we'll also host monthly events like this one, where we bring together academics and economic communities to better understand the complicated factors that contribute to health disparities. On that note, we're thrilled to have 2 Harvard medical students with us today, Ayotomiwa Ojo and Parsa Erfani, along with their professor, Dr. Neel Shah. And Dr. Shah is a professor of obstetrics, gynecology, and reproductive biology at Harvard, as well as the founding director of the Delivery Decisions Initiative at Harvard's Ariadne Labs. In addition to his many publications, Dr. Shah is the senior author of the textbook, Understanding Value-Based Healthcare. Thank you for being with us, and I'll turn it over to Dr. Shah and to Tommy and Parsa.
Thank you so much, Jennifer. Thank you to you and to Benson and to Kirsten for founding PTEC, and as such an important and timely response. And thank you to the 9 life sciences company that are sponsoring and supporting this, and to all of you who are taking time on a Monday to engage in this really important conversation. I'm here with 2 Harvard medical students, and they're not just medical students, as you'll see in a moment. They're really extraordinary leaders in their own right. And I think part of the reason why we decided to do this keynote kind of kickoff conversation together is because of what happens when you have zero gravity thinking. So about 10 years ago, I was them. I was a medical student, and I noticed that, generally speaking, medical students, residents, faculty in academic institutions, they don't take care of the people with the deep pockets. And I noticed that very few of the people we were taking care of could really afford what we were recommending, and very few of the people on the front lines had very much insight into that. And that issue has not changed that much in the last 10 years. In fact, 2020 is the least affordable healthcare has been in the last half century for the average American. And as a clinician in the trenches, it occurred to me 10 years ago that very few people go to medical school to treat the GDP. And there was a conversation about healthcare costs in our country that was really abstracted to the population level and away from the need to really affirm the dignity of the people that we care for. And so I wrote a book about it and started a nonprofit that was trying to get clinicians engaged in this issue, and was part of this movement to advance policies around this notion of value-based healthcare. But I didn't get it all right. And in fact, I think the first thing I'll say is to really address this issue, we have to be able to get down to the studs of the system, not just personal practice, not just systems within our healthcare delivery system, but really the structures. And the only way to do that is with policy that's thoughtful. And along those lines, I think a lot of people who've been in these spaces, myself included, have congratulated ourselves in some ways for improving care on average. And you can do that and feel pretty good about it while also leaving some people further behind. And obviously this moment has made that very clear. COVID-19 has divided the world into people who can protect themselves and people who cannot. This is true not only across geopolitical borders, it's also true across neighborhood blocks in the same city. A lot of my family is from Jackson Heights, Queens, which was the neighborhood. It's an immigrant enclave that has the Elmhurst Hospital and had a very early and very difficult experience with the pandemic. And it is all of our collective obligation to make sure that no hospital in America, whether they're in Bismarck or New York, experiences what the Elmhurst Hospital experienced in March and April, and really do so in a way that's attentive to who is being impacted and why. The ways that the biology and the sociology come together, the fact that some people are less able to, through their occupation or through their living circumstances, protect themselves from exposures. And so I was really, of course, I had a chance to get to know Tommy and Parsa along the way in their medical school journey, but they came to me several months ago and wanted to write this piece about how value-based healthcare needed to value Black lives specifically. And we recognize, Tommy, Parsa, and I, that there are many injustices and there are many people who are marginalized and oppressed in American society. We chose to focus on Black lives for this piece as an extreme form of those injustices, because even within racism, there's racism, and then there's anti-Black racism, and there's anti-Native racism. And that's really important to recognize, particularly in my own field of obstetrics, where one of the clearest signs of structural racism in America are disparities in maternal health that are irrespective of education or income. So anyway, Tommy and Parsa came to me and they wanted to write this piece. They made me realize I had missed something, even after writing an entire textbook. And they got to work and really they did this. They were examining the healthcare system as students with fresh eyes. It was their expertise from their vantage embedded in the healthcare system that led to these ideas. And so they're going to tell you about them. And that's what I have to say. So Tommy, Parsa, I'll turn it over to you.
Thank you so much, Neel, for that kind introduction. And thank you all for having us. We're excited to be with you this morning. And so I would just like to share a little bit more about Parsa and I's vantage point and what leads us to think about equity and value-based healthcare. And so this all starts in April, and actually probably starts way beyond that, but a moment I can remember is in April, sitting in a session about value-based healthcare with Dr. Tom Feely, who was the lead in setting up a value-based healthcare system at MD Anderson. And so he was talking as an intro about value-based healthcare as being the solution to one of the most pressing issues of our medical system, right? It's very costly, but we don't see better outcomes, especially when you compare us to other developed countries. And we were discussing key principles around value-based healthcare of measuring outcomes and costs for every patient, setting up systems of excellence, and creating systems and regional care delivery centers that reached patients right where they were at and that we were meeting their needs. And as I was hearing these principles, a thought that came to my mind is, where does equity fit into this? Why is equity not a key principle of the value-based healthcare system as it's being explained to us? A lot of our low-value care happens amongst those who are systemically marginalized, happens among community of color and low-income people, people who have been excluded for way too long. And like Dr. Shah mentioned, maternal mortality is one of those things that sticks out very sorely to me as someone who aspires to be an OBGYN. Black mothers, Indigenous mothers in the United States are 3 times more likely to die in childbirth than white women. And when you look at the maternal mortality outcomes in the United States and you compare them to other developed nations, we rank at the worst. And so from a value-based care perspective, that's low value care. And what drives that low value care? The disparities we have in our country. And so what I'm thinking is, how does value-based healthcare then seek to address the inequities here that leads to looking like we have a low value system? And so as we were discussing more about value-based care, and we were talking about it in the context of MD Anderson and the integrated practice units that they were setting there, and we were seeing improved patient outcomes, better patient satisfaction around their cancer care. And in the appendix, one of the last things we talked about, we looked at the map of Houston and the surrounding areas and who was captured by the value-based care model, who was under this system. And what I noticed, and I think what other classmates noticed, is that these were communities around Houston that don't have that many Black and Latinx people, even though Houston is a very diverse city, has a robust Black and Latinx community. And this is in the setting where Black Americans are 2 times more likely to die from prostate cancer, from breast cancer, from stomach cancer. And so I was just thinking, what is value-based healthcare doing to address these disparities once again? And when I look at a map like that, I'm also thinking of before 1965, when hospitals used to be segregated, Black patients couldn't get care in the white patient wards. They were relegated to basements of hospital buildings, if allowed at all. They were the last to be rounded on. The last patients nursing staff would come and check. They were receiving second-class care. And I bring this up because when we think about inequities in care and who's included and who is not included, we must look at history. None of the inequities, none of the disparities we see now happen in a silo. They're all related to things that have happened over time. And so while addressing equity, while thinking about value-based care, all of this is multifactorial, and that's why you all have done the really important work of bringing people from different perspectives together. I think as we move forward, there are like a few questions that Parsa and I have been asking around what it would look like to include equity in this new payment model.
Thank you so much, Tommy. And thank you again for having us. We asked a few questions to start thinking about how to integrate value-based care and equity together. And one of the first questions we asked is, who's part of value-based care models to begin with? If we believe that value-based care is a mechanism to improve quality and care in the United States for patients, we need to ask ourselves who we even let in the door. In 2015, about 11% of Medicare beneficiaries were Black and 8% were Hispanic. But in the Medicare Shared Saving Program, ACO, only 9% were Black and 2% were Hispanic. And as Tommy discussed in the MD Anderson example, having some populations benefit from value-based care while excluding others, the question remains of how these exclusions affect existing disparities. The second question that we asked ourselves is, once we let folks in the door, how do care delivery models or QI interventions affect existing disparities in the participating population? And what are we actually doing about it? As Neel mentioned, value-based care usually relies on a measure of central tendency when looking at quality metrics. And that comes with a caveat that we can see quality metrics overall increase, even if people in the fringes of that quality curve are left behind. And in the past 20 years, we've seen different models in QI interventions that have improved existing disparities, some that haven't affected disparities at all, and some that have widened the existing gaps. And often what we call that latter widening of the existing gaps is that it's the unintended consequences of these models or interventions. And rather than defining these consequences retrospectively as being unintended, we found it integral to think about how we can proactively design incentives and mechanisms to prevent these consequences to begin with. And as we learned about the ongoing work in this field and saw how different stakeholders were approaching it, we started to see that there were basic steps that had to be taken towards moving the pin forward on this integration. One of the first steps was around developing or needing health systems to not just measure the average quality anymore, to actually having people increase their granularity and measure and report the spread of quality among different races in their population, and also track how new innovative models are affecting different races differently. So considering who we let in the door, and then how people fare once they're inside the model. The second step that we found to be integral was investing in the development and implementation of quality metrics that are grounded in equity. So measuring differences and developing equity metrics wouldn't be enough, but rather tying these equity metrics to rewards and penalties would be integral to incentivizing disparities reduction at the commercial level, the government level, and the health systems level. And we hope and believe that formally incentivizing disparities reduction will push health systems to invest in existing evidence-based models that address social determinants of health, or develop new justice-oriented interventions for their health systems. And one of the difficulties that we'll need to overcome in integrating equity and value-based care is bridging across disciplines. For example, folks who work in health economics and folks who work in health equity and social justice often exist in their respective silos. They use different languages, they approach problems with different perspectives, and we've seen this in the academic spaces, in industry, and in the nonprofit sector. And we believe that bridging this gap and breaking these silos will be integral to achieving high value care in the United States that is equitable and is anti-racist. And that's why we're really excited to be here today and learn from you all and see these forums convene.
Thanks, Parsa. And so lastly, we know that in identifying meaningful equity metrics and building our current health information systems and implementing programs, evidence-based models that work, that these are all high cost upfront. But we do have existing measurement tools. We do have coding systems in place that we can leverage to build this further. And we also know that we do have evidence of models that work. We do have evidence of interventions that can bring us closer to equity. And so when we wrote this paper, and we will continue to think about equity and value-based care, because value-based care is going to increasingly be implemented to address one of the biggest issues of our time, rising cost and healthcare inefficiencies. But healthcare disparities are also one of the most pressing issues of our time. It produces inefficiencies, it's very costly, but most importantly, it's costing us human lives. Adapting value-based healthcare is a necessary step to improve health for those on the margins and therefore bringing us closer to equity.
Thank you, Tommy, Parsa. That was amazing and such powerful stories. I just want to thank you for sharing that with everybody. It's something that Dr. Shah mentioned previously. It's interesting that when individuals who look at it with a new lens are able to show us things that we really should have considered a long time ago, but by your vision and your ability to kind of see this in a new light really brings forward some amazing thoughts, and thank you for that. Parsa, you mentioned metrics to reimbursement, and that's obviously the topic of today's talk, so I appreciate the transition. Now I'd like to introduce the panelists that will kind of discuss this a little bit more. And what you'll see is that the way that we structured our panelists is to have multiple perspectives. We'll have a perspective from healthcare delivery, a perspective from health system leadership, a perspective from data and metrics, and the use of advanced analytics. So let me introduce the three panelists. First, Dr. Barbara Terry is a consultant at Tribamba, having previously held roles as the Vice President, Mission Effectiveness and Chief Diversity Inclusion Officer at Pinnacle Health. She was also previously the President and Chief Executive Officer at the Institute for Healthy Communities. Next, we have Dr. Michael LeBeau, who is the President of Sanford Health Bismarck Region in North Dakota and a board-certified adult nephrologist. He's also a member of the Sioux tribe and has served the Native American community throughout his career at Bismarck. And lastly, we have Mr. Murray Aitken, who is the Senior Vice President at IQVIA and the Executive Director of the IQVIA Institute for Human Data Science. an institute focused on improving patient outcomes through managing costs and maximizing access. He was previously a partner at McKinsey & Company covering the life sciences industry. So we're very excited to have the three panelists with us here today. To kick things off, I'd like to direct the first question to all three panelists. Maybe start with Dr. Terry, then Dr. LeBeau, and then Mr. Aitken. And the question is this: health equity is brought to the forefront of attention due to the glaring disparities seen through COVID-19 morbidity and mortality, as well as the systemic racism brought forward by the death of George Floyd and countless others. What do you see as the biggest barrier to improving health equity here in the US?
Certainly, I certainly strongly agree with our panelists, and I really enjoyed their presentation. I think one of the biggest areas, one of the biggest barriers is first an understanding what health equity is. When we think about health equity, we mean that everyone, all people, have the resources, have what they need to be able to access health services as well as other services in order to maintain their life as well as to lead productive and meaningful lives. So sad to say, most people don't really understand what it means. We can talk about social determinants of health, but even with it across the board in healthcare, it takes a lot of understanding for people to really come to a common understanding of what it means. Because we recognize that not all people, sad to say, have the same access to healthcare services. Not every community has the same access. So what we need to do is really bring about a common understanding of what it is, what the barriers are, what are some of the underlying factors that cause health disparities and health inequities. I think that's one of our biggest challenges, is really developing a common understanding from person to person, from group to group. And it really requires bringing a lot of people together to address the issues, which can also be a secondary barrier. I think is really not only having that common understanding, but being able to bring people to table that will provide resources, that will enable us to be able to look at what are those underlying factors, as well as some of the factors that perpetuate health inequities. Really having an understanding of all of that, I think, is one of our biggest challenges in order for us to really address individuals as well as disparate populations, help them achieve better health, better well-being, and certainly strongly agree with what our presenters have shared with us in terms of what it takes. It takes a lot of people. It takes addressing health policy. It takes addressing the financial aspect of health and every other aspect of health as well. So I think our biggest challenge is having that common understanding.
Yeah, that was very well said. I really appreciate that, Barbara. As I think about the system, first off, love the presentations, and I love the optimism in the presentation, and how, as we battle this, how this might be something that, if we do well, actually now becomes a cost savings for healthcare. I love the discussion of quality, and I think that's our best opportunity to get into this arena, is in at-risk or quality-based payments. I love the comment that it's the lack of understanding that I think really is the biggest barrier from a healthcare systems perspective. And it's the understanding of the individuals we serve.
Yes.
A big thing is that lack of trust. And the harder I try, the further I get away. Many times I don't know exactly what the questions are I should be asking. I like the idea of community wellness. Obviously, when I think about it, I think through the eyes of a reservation, and you have to focus on wellness. And I think the definition of wellness for each of us is different, and to be able to speak a common language. And then the last thing I'd say is, just from a systems perspective, I agree, it takes an army. And that's what's, I think, so great about this movement, is you get a lot of people to the table. And I just think from the federal government, just through the eyes of Indian Health Service, if it's 43% funded, it's really difficult to develop any type of system that's going to sustain excellent outcomes. And so appreciated, like I said, I very much appreciated the insights, and I'd love to hear, let's go on offense. Let's find the positive stuff that's going to make us better going forward.
So if I can add some comments here, I would agree with I think everything that's been said to date, and I'm an optimist at heart, so I also bring a positive view towards what we can collectively be doing in this area. The approach that we tend to take is we refer to as applying human data science to these issues, and what we mean by that is really the combination of understanding about human science with what we understand about data science, and bringing those two together, we think is a relatively novel but can be very effective way to working our way through any manner of issues, including these issues of health equity. We use the word human when we talk about human data and human science to deliberately mean we need to open the aperture beyond that of patient data or patient science. And I think that remains the largest barrier, that we are still tending to talk about things in the context of the health system, the way in which individuals interact with the health system, and I might say the information that gets gathered when an individual interacts with the health system. Yet we all recognize that what happens with the individual outside of the health system matters a lot, and we know that the social and behavioral factors matter more than the quality of the care that the individual receives when they do interact with the health system. Yet, frankly, we tend to somewhat blithely sort of ignore that understanding and carry on our way focused more narrowly on healthcare. So, my call to action is to ensure that we are looking at things through that broader lens, and that we step beyond the sort of narrow view of what has to happen in the health system in order to bring equity. I would also just add to that we also know that there's a fragmentation between healthcare and social care in this country. And I think when we look around the world at other health systems that increasingly are bringing social care and healthcare together in an integrated way, with an integrated budget, by the way, that is an important direction that I think in this country we've yet to make much progress on. So we end up with our, again, fragmented approaches to trying to deal with the underlying issues that manifest in the equity and the disparities that we've been talking about. And I think this is something that we want to be taking on if we're going to fundamentally tackle this issue.
Thank you. That was amazing. I love each perspective views kind of building on each other. And Mr. Aitken, I love the fact that you're looking at outside of the health, looking at everything else as well, and how everything influences to that common language and to what the community needs, from Dr. Tushar and Dr. LeBeau. I like to kind of focus a little bit on the questions, and starting with Dr. LeBeau. As a member of the Sioux tribe, you serve as a provider in your community and witness firsthand the disparities that exist in that community. We have two medical students who kicked us off today, who may have a little bit less experience compared to you when delivering the care. What are some of the lessons that you wish healthcare providers who may not have had your experience know as we have this discussion?
I like the idea, when we start saying, what are we going to measure? What are we going to deem success? And I love the data of how are we going to put it all together? If you go south of Bismarck and get to the reservations where I'm from, if the average life expectancy for a male is 56 or 58, and we start to say the benefits of blood pressure control or blood sugar control, It's a completely different argument at 56 than it is if your life expectancy is 82 or 84, even for some of our populations. And so along those lines, if you just think about it, I think we got to ask ourselves different questions. What are we trying to deliver? I many times made fun of myself. And I took care of a lot of folks that came from tough backgrounds, really just had things going, and they could just barely keep things together. They could barely get out of bed to come and see me. Whether it was due to depression or socioeconomic status, whether it was due to alcoholism, you can pick, but they would come to see me, and then our conversation might be me asking, how many carbs are you taking in at lunch? And how many units of insulin are you taking per carb? And the disparity of how I picture what I should be doing at that visit and what they need from me is just light years away. And that's the one thing I think I learned over my time as I took care of these folks is I'm really there for them, not me. And so at the end of the month, I get a report of what percentage of my patients have optimal diabetes measurements. You know, many of those folks needed me to help with just simple things, wellness. And really, what's my job as a doc? Is it to treat and get numbers correct, or is it make people feel well and be well and healthy? And I think that's something that we should think about. I think the other thing is in the delivery of healthcare. I think a little differently now as my career has changed. How do you deliver care, and what's going to be the expectation of how we approach people when they come in? And so without being able to develop, and this has been a really unique time to think through these things. If a community doesn't trust me as a healthcare provider or deliverer, that's the fundamental need. And so now, as providers, we ask people to make really hard decisions. Go without, spend more money. You know, a third of our folks, or a fourth of our folks at least, are rationing care. And so do you trust me that you should pay for this medication at the expense of X? And to me, the fundamental of lack of trust has to be dealt with before we can deal with anything else. We ask so many hard things of our patients. And as a healthcare system, it's even worse. We ask communities to believe in us carte blanche. And so I think it's so important that we figure out how to bridge that before we go further. And then just the last thing I'd say is, you know, and I love the human part. I love that. That really resonated with me. We got to remember why we're here. And it's really to serve our communities. As providers, it's to serve our patients. And it's really easy, even if your heart's in the right place, even if we're trying our hardest, it's so easy to get caught up in what's important. I love Tommy and Parsa's presentation, and I love to hear that in the world of quality, we're going to offer better care. And it's going to be a bridge we use to change our delivery system. And so that's what I think.
Thank you, Dr. LeBeau. That's amazing. I love that idea of trust. You know, as each panelist is coming up and talking, there's all these nuggets that are coming out. So I'm going to use your answers and kind of continue the conversation with Dr. Terry. You've sat in so many roles as senior healthcare leader, and you've been exposed to multiple health delivery systems, community organizations, academic networks. I'd like you to discuss a little bit about how reimbursement practices, going back to the title of our discussion today, how reimbursement practices may influence community behavior, kind of hinting at that human data aspect, provider performance, and what Dr. LeBeau mentioned, and even educational pipelines, looking at Tommy and Parsa. How can all this kind of be brought together, and how can we influence that behavior?
Certainly excellent, and having had a lot of experience, as you mentioned, in that area. When we're talking about our health systems, and as was already said, we really need to think about, even though we need to put all these systems in place, protocols in place, health policy needs to be in place, but we cannot lose sight of the fact that we're dealing with human beings that have real issues, that have real problems. It's so easy when we recognize the fact that most of our African American Hispanic population has heart disease, diabetes, asthma, all the things that we expect of them, but yet there's no grocery store where they can go and afford some healthy foods. So we really have to think about it. You know, we have patients that have asthma, children that have asthma, but look where they're living. Their environment is really bad and their air quality is really bad. How do we change all of those things? So as we think about pay for performance and the same things that we've learned, I had the great opportunity of spending about a year with Innovation Associates when I was with VHA. Went for training to learn about Don Berwick before he became the vice president over Medicare. But anyhow, I learned from him about fast cycle process, how we apply best practices to improve the emergency room, to improve the operating room, all these things. But once we put these protocols in place, so often we forget about the persons that we're trying to deal with, the persons that we are trying to make their lives better and help them have a quality life. So I think one of the things we need to do is we talk about pay for performance. It's, you know, we already have it in place as it relates to our clinical issues and some of the things that we're improving: heart disease, improving care of diabetics, making sure they get education, making sure their A1C is at the level where it should be. We need to take some of those same systems and practices and put in place various incentives, pay for performance protocols that will help people become better and lead better lives as it relates to disparities. I think we have a lot of models out there, but I think the challenge is applying those and really applying those to the healthcare delivery system, which has been very stiff, very hard to change and manage over many, many, many years. And I have found too, as we work with healthcare leaders, because of COVID, there is a spotlight right now on health equity. A lot of our health systems are blending that into their population health management activities. They're really looking at it. And so one of the things that we can really think about in terms of what good is coming as we go forward after COVID and think about it is the fact there is a strong focus on systemic, deeply rooted racism and health disparities. So I think we have people at the table and there's a lot of models going on. We see where payers and pharmaceutical companies like Highmark and Aetna and Walgreens and CVS are working together. They're working collaboratively to address health equity and to address health disparities. But I think they also need to put incentives in place for our health systems. We often believe they have all the money in the world, but that's not always the case, to be able to change and be able to put systems in place. And as I mentioned earlier, having had experience with Don Berwick, it is true that if you improve quality and you improve the patient experience, you can reduce the cost of care. So we have to continuously help others understand that that is possible, and bringing business to the table. Working with a group, I had the opportunity, another opportunity to work in Hungary to improve health of women and children. And one of the things that we did is we brought business leaders to the table, Ford Motor Company and some of the top oil companies, because they began to realize the cost of care was coming back and hitting them as well. So what we need to do is really bring foundations to the table, health payers, pharmaceuticals, as I mentioned earlier, particularly the business community, and put mechanisms in place where we can have pay for performance, where we can have incentives in place for people to really be able to make a change, and to be able to have measures, of course, in place. Not forgetting about trust or the human being and how important that is, but also having some resources available so that people can work together to improve health and quality of life. And I don't want to forget government. It's important. I was very instrumental in working with our Department of Health in securing funding to help support our community initiatives around Pennsylvania. So those are other people who will really be willing to come to the table and help provide resources to improve health equity and to create comprehensive measurement systems, best practice systems, put them in place to be able to address health equity.
Thank you, Dr. Shah. I love that. I love kind of pulling together all the parties. when you started, one of your opening remarks was about getting people to the same tables and bringing different tables together. And I love how that kind of consolidates together around reimbursement and incentives. And you had a nice segue from Mr. Aitken to talk a little bit about data. And before, I'll be very transparent, before we started the panel, I had sent questions out to everybody, but I'm gonna change the questions a little bit because of something that was said. So to Mr. Aitken, you've previously been very involved in healthcare data analytics from the beginning at EMR, and this is the change. You talk a lot about human data. So it's outside of EMR, it's the healthy data, not the illness data. So in that light of both healthy and illness data, can you give examples of how unintended consequences on payment and delivery may come from metrics and standardized measurements? We've heard a little bit around already how standardized care may not be that connection to the patients that we really want to strive for, that we don't understand what they are living and experiencing. Are there aspects of that in metrics as well?
Yeah, so I will, there are, and I'll talk about those. But before I get to that, I just want to add one more comment about human data science relating to what Terry was just talking about. And that is that we also connect human to data science partly through the type of data that's gathered and looked at, but also importantly, what comes out of data science only brings value to a patient, a community, to a system, if a human makes a different decision or takes a different action as a result of what data science is generating. So we can get very excited about algorithms and AI and all of this, which can be applied, to broad sets of data. But if what emerges from that doesn't actually result in an action or a behavior change, then it doesn't bring any value. And I think we often tend to only think as far as the metrics, the data, without connecting that to the downstream change that is required to yield a benefit. So I would just sort of plant that idea as well. But in terms of the sort of unintended consequences of this focus on metrics and standardized measurements and so on, I mean, I think there are examples of where efforts in the past have gone, perhaps a little bit down a pathway that might not have been intended. I think the hospital readmission reduction program, for example, which got a lot of attention a few years ago and clearly precipitated changes in the way hospitals thought about their decision-making, both in terms of discharge, the nature of the discharge instructions, and so on. And caring about that transition of the patient back to the community. But I think there's a reasonable amount of evidence that it also triggered patients not being brought back into, not being admitted back into the hospital, and instead being treated as an outpatient or in the emergency room, when in fact that didn't necessarily result in the best outcomes for the patient. So that's one where, again, there's some amount of evidence that program did result in a behavior change that inadvertently actually resulted in patients not receiving as good a care as they might have deserved. I think the star ratings and the incorporation, so star ratings have been sort of, again, an important mechanism to focus attention. Medication adherence is one of the elements of the star ratings, and we've been observing through the data we gather the significant shift towards dispensing 90-day prescriptions for chronic therapies. And we look at that and wonder if there's been a little too much emphasis on just getting everyone to take a 90-day prescription without necessarily knowing if they're using it appropriately for the full 90 days. And in some cases, if you don't stop it, you'll get the next 90-day prescription filled as well. So, that's another area where we see a good intention that if it's left to its own devices, can end up with things moving down an unintended track. I think also to the comments from Dr. LeBeau as well, we can become more fixated on the metrics than on the patient, and that's not the intention either. So I think this is also where we need to have this balance of evidence and evidence-based decisions and metric-based approaches to understanding the current state and any improvement in terms of dealing with the issues of equity. But we can't let that overwhelm the human interaction with the patient. It's a little bit like the extent to which the EHR, while a wonderful mechanism to gather lots of data when the individual does interact with the health system, let's not have entering information into the EHR distract from the human eye contact when engaging with the patient. So, I think those are some of the ways in which a well-intended direction can head off in a slightly suboptimal direction. I think what's key is we all keep our eye on the prize, and that we have a shared interest and understanding of what that prize looks like, and use that to be more perhaps dynamic in the approaches that we take. So it's not a fixed approach that we just sort of roll out and let it happen, but there is a means to dynamically adjust the approach as we progress. So there are things that can be done to ensure that we stay on track and that we stay with that prize of reducing inequity, front and center in mind.
Mm-hmm.
Thank you, Mr. Aitken. So as a previous data person, it hurts me a little bit to know that data isn't the end all. But I really appreciate your comments, and the unintended consequences definitely weigh heavily as we consider the idea of metrics. I'm looking at the time, I like to kind of conclude with giving each one of you an opportunity to offer some final remarks. But I want to kind of shape it a little bit if I can. We know that a new administration will be coming forward here shortly. We know that there's likely going to be changes in the way that health is going to be perceived by the new administration. So as you think about your concluding comments, I guess the question that I like to tag on top of that is, if you could tell the new administration one thing in regards to health equity that they should know or they should consider doing one thing, what would that one thing be? And I'll kind of keep the same order. So I'll start with Dr. LeBeau, Dr. Terry, Mr. Aitken. Dr. LeBeau?
I think as we go from administration to administration, I don't like to see it as a political term, and I would like our conversations to be different. Not about who pays for health care, but how we deliver health care more efficiently and more effectively. Like I said, tying right back to our initial presentation, like I said, first I'd like to say just grateful to be part of this. It's actually been, I think, more educational for me than anything I'm going to give people. As I think about how we deliver care differently in a quality-based care, it really becomes then, I think, imperative that we think about how we do it with social equity in mind. We've heard lots of good stuff. I appreciate, all the nuggets that come out, and you think about different groups that we're trying to take care of. So I think it's not about cost reform as much as it's about delivery reform. Mm-hmm. And in delivery reform, we now all have the ability to do it better for all those that we serve. And in my mind, like I said, it starts with trust and understanding. I think the two things in my mind that we really should be thinking about.
Thank you. Dr. Cherry?
I don't want to sound like a broken record, but as we talked earlier about bringing groups together that would help dig up or discover those resources that we need in order to be able to improve health equity and reduce health disparities. But we also need to engage patients. We always assume as healthcare providers that we know what they need. I've heard that all over the years. I've been a hospital administrator, a consultant, a CEO of a two statewide organizations. We always think we know what they need. But in order to not only build trust and not only strengthen those relationships, we need to engage people. And we need to engage the people that we want to affect most. And that are those who are experiencing health disparities and those who have felt that they've been marginalized and they feel that, because we can only understand what they've gone through when we talk to them and really get to know them in such a way they can help us understand. Then we can bring about, I think, a change in how we deliver systems. We also have to keep in mind that health systems, and I don't say this I'm not speaking of those of you who are working with health systems, maybe put it that way, but some people don't have a long level of understanding of sticking to something. We need to be in this for the long haul. I really feel that we are our brother's keepers as health providers. We are accountable for those who are not receiving quality care and those we are not improving their health, their quality of life, and their meaningful life. We need to really be able to take care of them in such a way that we can change our systems by better understanding who they are and what their needs are. And so even though we need the resources, we need the partners, we need health policy change, we need to bring together health and social well-being, all those things, and address social disparities of health and all of that. But we certainly need to engage people that we're serving so we can better understand what they need and be able to be committed to what they need and be committed for the long haul.
Thank you.
I would build on Dr. Terry and Dr. LeBeau and agree with everything they've said in terms of advice to the next administration. But I would also say that human data science is a useful frame to think about these issues. I do think that ignoring the fragmented approach between social care and healthcare is a major impediment to progress. I think we need to be harnessing the power of technology and data, the cost of which keeps decreasing every year. So let's grab that opportunity to harness the power that gets us well beyond averages and really helps us understand what's going on at a segmented level. In a way that's also dynamic and reflects what is changing around us. And to do all of this, as the other speakers have said, not in a fragmented way where we're all off in our corners, but in a way that does bring us together and apply the multi-stakeholder approach. I would just reiterate this issue that if we don't get to the fundamental issues of racism, of trust, then, for all the metrics, for all the tinkering around the edges, we may feel good about it in the short term, but fundamentally, it's probably not going to move the needle in this area. So let's ensure we sort of double down on getting our arms around those fundamental issues, and that very much begins by listening and understanding.
Thank you. I was just writing some notes as the three of you were speaking, and this is one very inspiring and two very eye-opening. The idea of, even though we're talking about reimbursement, to not fixate on costs, but to fixate on the change in delivery, the idea of bringing trust into the communities and the fundamental changes within the system using technology. This is not going to be easy. It seems like this is not going to be a a quick fix, as Dr. Cherry mentioned, that we have to be in it for the long haul. So I just want to first say thank you for the panelists for taking the time today to share with us your knowledge, and also to Tommy and Parsa as well. And I'll pass it over to Kirsten at this point.
Thank you so much to all of our speakers and to those of you who took your lunch hour or whatever hour of the day it is where you are to speak with us. We will be putting up this recording on our website, which is PTEC, PTEChealth.org, and also posting it on LinkedIn. This is a series of events which will culminate into a funded research agenda that we will put out in the organization mid next year, with the idea that we will both be listening and also ultimately helping to stimulate a body of research around metrics and around equity. Because as we know in healthcare, what gets measured and paid for is what gets done, for better or for worse. And that's a simplistic way of putting it. But particularly as we're thinking of a world where we're shifting more towards payment for outcomes, we would like to be bringing together the economists, the med students, the caregivers, the systems designers, and the private companies and public organizations to help increase the body of evidence that could inform care that is not just improving health, but that is improving health equity, so that we're not just getting healthier on average, but that there is a smaller gap between the most and the least healthy person in our country for greater social justice. So thank you all. Thank you especially to our speakers, to Benson, to Jennifer, and to our pro bono support, as well as our life sciences companies, all of whom are listed on our website. Have a great rest of the day.
Thank you.
Thank you.
Thank you.